Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. Here's Dr. Weiner.
Tonight, we're going to be talking with one of my colleagues in radiation oncology, Dr. Ranjit Bindra, about cancer of the brain, which is one of the most complex and difficult types of cancer to treat. There are a number of different types of brain tumors, but the most aggressive of those, that is glioblastoma, is one that continues to challenge us. And there is much research going on, both related to glioblastoma and to other forms of brain tumors, which we'll be touching on as well. So I'm very pleased to welcome Dr. Ranjit Bindra, a physician scientist at the Yale School of Medicine, co-director of the Yale Brain Tumor Center at Smilow Cancer Hospital, and the leader of the Bindra Lab at Yale. Dr. Bindra is very much at the forefront of brain cancer research, and his laboratory has done pioneering work. So we'll talk about a whole range of subjects. Ranjit, thanks so much for being on with us this evening.
Thanks so much for having me.
It's a real pleasure. So maybe you could just start by introducing the listeners a little bit to you. What got you interested in both radiation oncology and what got you interested in brain tumors?
Yeah, well, thanks so much for having me again. I started my journey long ago. I was a Connecticut native, went to Yale as an undergrad, and then came back here for my MD PhD program. It was during that time I was working in our now chair, Peter Glazer, in his laboratory. And my father had actually been diagnosed with metastatic esophageal cancer about halfway through my program. It was there that as I was working in a basic research laboratory on things like DNA repair and the tumor microenvironment that I got very, very personally inspired to work on cancer. Soon went on to Memorial Sloan Kettering to do radiation oncology residency and a postdoc at that time, and came back to Yale. And really that was the beginning of my journey in this area.
Yeah, it is remarkable how many of us have some sort of cancer history, either ourselves or in the family or what have you. Of course, cancer is common, so many people in the world have experience with cancer, but I think it's probably a slightly higher proportion of people who work actually in the cancer field. So, as a physician scientist, you are both a laboratory scientist and a clinician, and I might add a clinical researcher as well. What part of that work stimulates you the most, or is there no single part?
I think it is actually being able to jump between all the different worlds. I'm constantly inspired by patient encounters. They stimulate new ideas and thoughts, which I can kind of rush back to the clinic, from the clinic rather to the laboratory, and bring those ideas, those complex problems that we can then solve in the laboratory, and then bring them back to those patients. And it allows me to tell patients, when often they'll say, is there hope in the future? And I said, we're working on this. And that's something that gets me very excited to operate in those different worlds.
We've had a relatively limited number of radiation oncologists on the show. Part of that is because there are fewer of all of you than there are surgeons and medical oncologists. But maybe you could just help people understand a little bit about how radiation works.
Yeah, certainly. And we always spend a lot of time with our patients discussing this, because it can be an area of fear for patients, and they often ask, will I be radioactive when I come out of the facility? And we often say, think of it as a light switch turning on and off. And when you're a kid, if you ever broke a bone and you got an X-ray, it was really the same thing. It's completely painless, non-invasive way to damage tumor DNA, and we try to protect the normal tissue, a lot like chemotherapy in many ways, but we can focus those X-rays on the specific areas that we want to treat while sparing the normal tissue.
Yeah, and there are situations, though, and I realize this isn't, to the best of my knowledge, generally done in the setting of brain tumors, but there are situations where people are somewhat radioactive after a treatment because the radiation is actually implanted in them. Can you just comment on that, since
Yes,
it came up?
Yeah, now a great point. So the one exception, what we call brachytherapy, which is a way to put seeds that emit a little bit of radiation just in the area that we'd like to treat. There's also something called radiopharmaceutical therapy, where patients can get antibodies, more often antibodies that have radioactive conjugates to them that they get injected into the body. And then those antibodies deliver the radiation. For some period of time, they'll be locally radioactive, but we always advise our patients how to sort of manage that.
Sure. And for brain tumors, how has the area of radiation changed over the years?
I think this is a particularly exciting area for us with advents of technology like proton radiotherapy, which soon will be at our facilities here in Connecticut. We're able to precisely sculpt the radiation beam specifically to target the tumor. In the past, it was very difficult to localize things. Our imaging technologies were limited. Our what we call our onboard imaging technologies, where we take a picture of the brain, the normal structures in the tumor before every single treatment. And even if the patient moves 1 millimeter in one way or one direction or another, we're able to adjust dynamically the radiation beams. And so there's a lot of advances in both giving more precise radiation that's also less toxic to the normal tissue.
And of course, when we're talking about the brain being tighter with your fields, that is, having the fields directed at the tumor as opposed to the normal brain, becomes particularly important.
Exactly. Millimeters can make miles of difference, as we would say, in terms of long-term cognition and preserving function.
And so while we're on general issues about radiation, so there's the new proton approach, and there will be a proton facility that we're very much part of here at Yale, in addition to some other hospitals. But then there are these two other particles that are often talked about: electrons and photons. And can you just talk about the difference between these things? I mean, even for me, much of this is pretty murky.
Yeah. I have an analogy that I use in the clinic that generally works well. Is if you think about throwing a ping pong ball against a wall, and you got a pillow on the wall, and it's sort of a weird analogy. But when you throw that ping pong ball against that pillow, a proton particle is like that ping pong ball. It stops right there and doesn't go any farther past it. Okay. Photons can actually go way past. They go right past that pillow, almost through the wall, and sort of die off, almost like a sound going across the wall. Electrons are a little bit different in that they're sort of sprinkling doses that stop immediately on contact. We can't deliver them more deeper than the skin to a couple inches. Whereas protons, you can precisely localize them really anywhere in the body, and literally the beam will stop right at the edge of where you're prescribing the dose. So incredibly precise tissue distributions.
So if I'm getting this right, with photons, which is sort of, for the most part, the usual form of energy that's used for radiation, you can deliver it whatever depth you choose to deliver it to. You can't control that it's precisely to that depth, which then leads to potentially somewhat unpredictable toxicity. Whereas with with protons, you are much more precise about that. Am I getting this right?
You got it. You got it exactly. And I think there's certainly some cases where those differences make a huge difference overall in toxicity and efficacy, and some areas where there probably isn't much of a huge difference, relatively speaking, especially in children, for instance. We need to use protons because these children will have 40, 50 years of life ahead of them for a secondary cancer to arise. And so minimizing the dose becomes absolutely critical.
And, I think that what many of us don't realize is quite how costly some of these facilities and machines are. And just to give people a sense, for a proton facility, and it's usually a facility that is sort of standalone, with just one machine in it. Give us a sense of the price tag, just so that the sticker shock that I once experienced, everyone can feel.
Yes, it is. It is surprising. First, we like to note it's about a football field in many cases size, depending on the facility, and can be anywhere from 50 to 100 million to up to $250 million. Because you've got to accelerate these protons at such high speeds and then localize them. It is remarkably expensive, but it is surprising when I discuss that with folks.
And why does it have to be the size of a football field or close to it even? I mean, that's huge.
Yep. And it's just like when you hear about those physics particle accelerators in Switzerland, where they've got to rotate and sort of steadily increase the speed of the particle so it can get to a range where it can be actually useful to deposit energy into a tumor. So you actually have to have a large area to do that.
Wow. So when we talk about brain tumors, in general, we're talking about potentially 3 different disciplines involved. There are surgeons, or neurosurgeons in this case. There are radiation oncologists, and then there are neuro-oncologists who typically get involved in giving drugs of various sorts. And you all collaborate together?
This is why I love our field, is in the world of the brain tumor space, we all work closely together to figure out, do we need all 3 modalities, 2 modalities, what is the combination? And it's a really highly collaborative process.
And at least for patients who have glioblastoma, the most aggressive form of brain cancers, what proportion of those patients really end up seeing a neurosurgeon, a radiation oncologist, and a neuro-oncologist, and wind up getting all 3 different types of treatment?
We would say it's very important, especially at Yale. We have a multidisciplinary tumor board and a service where you'll pretty much see all 3 of us. And I think you need the perspectives from each of those doctors. I'd say in the end, the majority of patients will get surgery. A large fraction will get radiation, and an equally large fraction will get chemotherapy. And then all 3 is quite common for GBM. In fact, it's the standard of care to get all 3.
Yeah, no, and what I failed to mention or ask you about is the role of other types of professionals. So people who may be speech pathologists to help people who have language problems, nurses, social workers. It's really a whole team approach.
It's unbelievably complex, and you think about the radiologist looking at the images, the pathologist looking at the actual tissue, and then the nurses and everyone else involved. It takes a village.
Well, we're going to have to take just a brief break. When we come back, I'm going to ask a few questions about other kinds of brain tumors, and then we're going to get into your research and some of the newer drugs that may be on the horizon. All right, we'll be right back with our guest, Dr. Ranjit Bindra, a radiation oncologist specializing in brain tumors.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, which provides a multidisciplinary approach for treating appendix cancer, including advanced surgical techniques like hypothermic intraperitoneal chemotherapy. Learn more at smilowcancerhospital.org. The American Cancer Society estimates that nearly 150,000 people in the U.S. will be diagnosed with colorectal cancer this year alone. When detected early, colorectal cancer is easily treated and highly curable, and men and women over the age of 45 should have regular colonoscopies to screen for the disease. Patients with colorectal cancer have more hope than ever before thanks to increased access to advanced therapies and specialized care. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for colorectal cancer. Tumor gene analysis has helped improve management of colorectal cancer by identifying the patients most likely to benefit from chemotherapy and newer targeted agents, resulting in more patient-specific treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to the second half of Yale Cancer Answers. I'm Eric Weiner, and tonight I've been speaking and will continue to speak with Dr. Ranjit Bindra, physician scientist who focuses on brain tumors. So we've been talking generally about radiation, a little bit about brain tumors, and the brain tumors we talked about are largely the most aggressive brain tumors, that is glioblastoma. But in fact, there are other types of brain tumors as well, and these are graded in terms of aggressiveness. Maybe you could educate us a little bit about the different types of brain tumors, because I know that some of your research focuses on both glioblastomas, but also on less aggressive brain tumors.
Yeah, certainly. So we always classify first brain tumors as sort of intrinsic or extrinsic. Intrinsic meaning coming from the brain tissue, and extrinsic coming from other parts of the body. We call those brain metastases. But in the intrinsic category, there's a pretty wide range of diverse tumors that often are classified based on the tumor tissue, the normal tissues that they come out of. Some of the peripheral surroundings of the brain can often cause benign and sometimes malignant tumors. We call those meningiomas. We also have the ependymal linings of the brain, which we call ependymomas when they become cancer. And then even within glioma, which is really in that the brain tissue itself becomes cancer, we have 4 grades. Grade 1, which is essentially benign, grade 2 and 3, which are low and high grade, and then grade 4, which is often called glioblastoma.
And for patients who have grade 2 and 3 gliomas, oftentimes these are individuals who live with these tumors for an extended period of time. Is that correct?
It is correct. Many of these patients either can present at a young age and the tumors can kind of smolder along for 10, 20 years sometimes. Some of them are slow growing and probably had started in their 20s and 30s, and suddenly they present in their 40s or 50s, incidental finding or whatnot. But there's a pretty wide range.
And just in the past couple of years, we've seen the approval of a new drug, one of the first to get approved for the treatment of these brain tumors. Can you tell us a little bit about that?
Yeah, it's a very exciting time in our field. We're starting to see FDA approvals in this space like at a rate that we've never seen before. In grade 2 and 3 gliomas, particularly grade 2, about 70 to 80% have a mutation in a gene called IDH, which is involved in cellular metabolism. And there's now a drug that targets that, a targeted therapy for these grade 2 gliomas, which is really exciting for patients.
Yeah, no, I mean, it was so exciting a couple of years ago that when it was initially presented, it was on a large plenary session at our biggest cancer meeting. And I think everybody was just thrilled to see this kind of advance in brain tumors. So maybe you can tell us about your laboratory and the kinds of studies you're doing and the types of drugs that you hope will come out of that.
Yeah, thank you. So our laboratory is focused on finding specific mutations in cancers and most often brain tumors, where we can develop a way to exploit the defect. What we realize is that cancers often acquire mutations to become cancer, but then those mutations themselves become an Achilles heel that we can go after with a drug.
And this is what people think of as synthetic lethality to some extent.
Correct. In breast cancer and ovarian cancer, the classic example, there's a drug called a PARP inhibitor, which targets the BRCA mutation. And that is exactly the type of approach that we take in our lab, but for brain tumors.
Yeah. So you go after what makes the cancer so that you can basically cut off its ability to remain a cancer.
Exactly.
What are some of those genes that you've been able to identify? What do they do?
So very interestingly, the IDH mutation that I mentioned earlier, several years ago, we actually showed that PARP inhibitors that are usually used for breast and ovarian cancer, particularly the BRCA mutations, we actually discovered in our laboratory that the IDH mutations induce sensitivity to that class of drugs. More recently, another biomarker called MGMT, which is silenced in about half of GBMs. We developed a next generation set of drugs that target that biomarker. We published that paper in Science, and we're now trying to translate that into the clinic.
And when these findings are translated into the clinic, what's involved? How long is this process? What's the fastest you think it could be? And what's the typical?
Yeah, I think this is been a humbling experience for me, trying to translate work from bench to bedside. You realize not only is it hard to make a discovery, to find a target, to find a drug against it, but actually to bring it all the way to patients. Typically, you'll hear numbers, years on the order of 15 to 20 years. I started looking back recently at this. Now we're finding 10 to 15 years. And I think even more exciting, we could probably get this down to even 10 years. But even 10 years is a long time, but it's needed because it's so complicated to bring drugs from the bench to the bedside.
But at least as cancer doctors, I think, you and I would both agree that if we could figure out a way to get that down to 5 years, so much the better. And, some of it ends up being about frustrating delays getting clinical trials up and running. And of course, when you do a clinical trial, you need patients to participate. And so if you don't open the study at enough centers, you're not going to have enough patients.
Correct. It's those types of things. And at the Yale Cancer Center, as you know, as our leader, we've been spending a lot of time on this. And I think we are making progress, and we are seeing lots of collaboration across different institutions, and the ability of pharmaceutical industry, biotech, and academia to all work together to get drugs faster into patients.
Now, you've also had the experience of being involved in starting some biotech companies. And I think many people find that necessary to get the work done because, of course, academic institutions are places where we take care of patients and we do basic discovery. But that whole process of developing a basic finding and making it into a drug and testing that drug is not really well suited for a university oftentimes.
That's correct. And I think every Thursday I see patients in clinic, brain tumor patients, and it reminds me of the urgency. And I'm an impatient person by nature. And while I love all the work we do in the academic setting, the goal isn't always to develop a drug and get it into patients. And often we need to go via creative routes like the entrepreneurship startup route. That's moves often at light speed in terms of bringing ideas by deploying capital, large amounts of capital, in a very focused manner to develop that idea into a drug and get that drug into patients. Often the biotech world is where we need to move for that.
I suspect that our listeners can hear both in the content of what you say and the way you say it, that you're both, as you said, a little impatient, but also somebody who wants to push the envelope. And tell me about pursuing innovative approaches and some of the frustrations with that, with the way we typically think about science and the way grants are given out?
Yeah, it's our most recent work developing an analog of a drug called temozolomide, and this was the paper we published in Science. We saw a patient that had become resistant to temozolomide and came back to my laboratory and said, we're going to make a new version of that drug. Well, it turns out making a new version of a drug, not being a chemist myself, is very, very difficult. And so I had to go to a wonderful lab here at Yale, Seth Herzon's lab, a synthetic chemistry lab, and the two of us worked together. He didn't study much cancer biology. I didn't do much chemistry, but we worked together to develop this drug. Our first couple grants were rejected. In fact, some of the reviewers said this would never work. Lo and behold, we got it to work. And a lot of this is about persistence and just not being jaded by people that say this isn't going to work.
Yeah, no, I mean, I think a frustration that sometimes people have is that in order to get funding, you have to almost have completed the work in advance. And I think we continue to need to support people who are going to be innovative and take risks, because that's how we're going to really move the field forward. And what I'm struck by, though, is that it's a patient you saw in clinic with resistance to temozolomide that made you want to do this.
It's why I love being a physician scientist. It's really an honor and a privilege to be able to work with patients because, as I said earlier, they inspire us every day. And when I came back, I still remember the day I came back from that clinic, and there was an MD PhD student, a 22-year-old kid in our laboratory, who I said, could you solve this problem? And he started drawing out the structure of the drug. And he said, I think I can do this, but I need a chemistry lab. And we went and got the chemistry lab, and he was off to the races. It's just so much fun doing this type of work.
Well, and of course, with cuts in federal funding and with cuts related to training grants, I think one of our big fears is that those 22-year-olds will get turned off from science because they feel like they're not getting supported. And we desperately need not to lose a generation of people.
This is exactly I tell this to patients as well, as they ask us, is there a future? Are there going to be new drugs in 5 years if this drug doesn't work? And I say, thankfully, this country and the world is committed to research and new ideas. To do that, we need those 22-year-old kids to come out with those innovative ideas and to push the envelope altogether.
No, I mean, it's we definitely need young brains. So with that in mind, you were once a Yale College student. You were an MD PhD student here. You're talking now, imagine, to a young person interested in medicine and science. What's your advice to them?
So my advice is, first, don't be scared. Of course, it's very uncertain times for us. Science has always been my true north. And as you're on the side of science, we'll always be right, because the pursuit of knowledge is what we need to do. There will always be problems that we need to solve and questions we need to ask. And health and human disease, I always tell people, we're all human. Regardless of what stage we are in life, how much money we are, we all need to help each other out. And people always get sick. And so this is a wonderful field to think about going into, because there's always going to be something to do to help our fellow humans, as I would say.
Dr. Ranjit Bindra is a physician scientist at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.